Hello all, and welcome to today's training, Optimizing Your Clinical Practice for Teletherapy with Dr. Robert Kyler, PhD.
Good morning.
Good morning. I am Mary Geist, Director of Programs at ADAA. Before we get started, I would like to go over a few items so you know how to participate in today's event. We have taken a screenshot of an example of the attendee interface. You should see something that looks like this on your own computer desktop in the upper right corner. You've joined the presentation listening using your computer speaker system by default. If you would prefer to join over the telephone, just select telephone in the audio pane and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's presenter by typing your questions into the chat pane of the control panel. You may send in your questions at any time. We will collect these and address them during the Q&A session at the end of today's presentation.
Mary, let me add there. I'm looking at my slide deck and I'm not seeing the interface. So can you be responsible for handling questions when we come to Q&A?
Absolutely.
Thank you.
You're very welcome. So I'd now like to introduce Robert H. Kyler, PhD. He's president of Clinical Psychology Consultants Limited, LLP. His consulting practice focuses on strategic planning and operations of healthcare organizations and practices. He provides consulting services in telemedicine, and his decade of telemedicine experience has included extensive activity in the clinical, public policy, finance, technical, and business development areas in the field. He is author, along with Dutch Holland, PhD, of the book Implementing Telemedicine, Completing Projects on Target, on Time, on Budget. He is active in the direct practice of clinical psychology and focuses on treating executives and professionals in crisis, as well as services to individuals with panic disorder, chronic pain, and headaches. He serves as clinical advisor to Breakthrough Behavioral, a division of MD Live, and clinical advisor to Palo Alto Health Sciences, which provides a free Sphere breathing system for treatment of panic disorder. So I will now hand things over to our expert and take it away.
Great. Thank you very much. I'm pleased to have the opportunity to visit with the audience today, and I take it by your participation that you are interested in or beginning to practice telemedicine or teletherapy in your clinical practice. And I'm going to be walking you through my experience of using teleconference as a way of delivering psychotherapy. I will address some things along the way if there are some physicians on board, a couple of pointers about the practice of medicine as distinct to practicing psychotherapy. And if you will please send your questions in, Mary will handle the Q&A. And I believe we're also going to be making the slide deck available for all participants, so that will be available for you. One of the things that we do is, as part of your participation, if you will write down the letters that are shown on the screen, this will allow you to take part in the CE credit, so you have to be able to list all letters. You should be seeing the letter A right there, and so that will be in your webinar evaluation if you will code those letters so that we can make sure that you have participated fully in the conference. So today I'm going to be talking about the practice of telemedicine via, and I'm trying to get my my slides to move along. Let's see here. I'm going to begin with a definition. Telemedicine in general, we consider the delivery of healthcare services at a distance via interaction between practitioner and patient. There is a much broader term that we're calling e-health, which is a very, very wide range of technology-assisted healthcare. But for the purposes of our presentation today, we're going to be talking about teletherapy, whether we frame it telemental health, telebehavioral health, telepsychiatry. We're going to be focusing on the delivery of mental health services at a distance via interactive audio and video technologies. and the self-management technologies that may be part of that. For the purposes of this conversation, we're not going to be talking about other things in any significance that regard text therapy or computerized CBT, though we'll reference that briefly. To discuss a little bit about kind of the fundamentals of telemental health, one thing that we can say, of all the medical specialties, we really are involved in the least complex technology delivery of any healthcare specialty. In order to provide mental health services in general, for all practical purposes, we need two talking heads. There's no need to lay hands. We're not palpating spleens. We're not measuring blood pressures, although those technologies are available. But telebehavioral health really has, in some ways, the simplest technology requirements of any of the medical specialties. Another aspect is that there is a robust empirical base for both the efficacy and the acceptance by clients of the provision of mental health services. I'll reference those in a little bit, but American Telemedicine Association has several different source documents that really summarize the empirical base for the delivery of mental health services. But I can basically summarize by saying that the literature suggests that mental health services, that diagnostic accuracy and treatment efficacy for services delivered over interactive audio and video technologies provide comparable findings to those when are delivered in person, face-to-face. I think another aspect that we are really seeing increasing evidence of, that consumers are very interested in technological avenues for accessing healthcare, and adoption by consumers just continues to grow. I can say that in many corners, consumers are maybe ahead of us practitioners in terms of their readiness to adopt technology. Another aspect that's really important in terms of why telemental health, us practitioners tend to be clustered in big cities, and there are huge needs in this country where practitioners do not live. So we have a significant distribution problem for face-to-face delivery of mental health services, and telemedicine, teletherapy can provide services to clients where they are and where practitioners do not live. I talked a minute ago about how teletherapy is really the easiest of the healthcare specialties, and I can say in a way that the technology is the easiest part. Getting a clinician on camera, somewhat like we're seeing today, keeps getting easier and cheaper. My first telemedicine projects involved business-grade video conference cameras. Doing it on the cheap was probably costing me about $8,000 to $10,000 per side, just in terms of equipment, and that did not account for the organizational investment. And so technology, I think most of us are probably on a laptop computer with a camera. For all practical purposes, that has replaced the need in many instances for the professional-grade dedicated cameras. Technology is the easy part, and therefore it's really easy to underestimate the organizational complications of delivering sound healthcare via technology. I use the analogy that, if Granny can Skype, I can do telemedicine. Part of my conference today is to acquaint you about some of the things to know about the technologies, some of the things to look out for, and a real focus on the kind of adjustments that may be necessary in your office, practice, or organization to implement telebehavioral health successfully. Our next letter for your CE credit is the letter O, so if you would jot that down. Now I'll address, why do telemedicine projects fail or underperform? I have to tell you, in my consulting business, I have seen a lot of what I call telemedicine coat racks, which really meant that equipment was purchased with the idea that it's the latest, sexiest technology, but the organization did not give sufficient focus on how the technology was going to be used and how the organization needed to adapt. I want you to think about, even if you're a solo practitioner, that you are an organization, and that the organizational steps necessary for you to offer teletherapy is not that different from a hospital system. The scale is different, but the basic principles are different. So what are some of the reasons that telemedicine projects can underperform? One, if there are equipment problems, if there's insufficient training and the equipment was too hard to use for either the end user or the clinician on camera, if picture or sound quality was poor, if there are complications in terms of infrastructure like scheduling and record keeping, and if there are staff in the mix that they were not trained well enough to fit telemedicine into their workflow, and they had expectations that they were really not sufficiently trained or compensated to incorporate into their daily work. Other reasons is that clinicians sometimes didn't find that there were benefits that were sufficient to justify the change in their office practice. It is quite different to boot up a camera than it is to have a client meet you in the waiting room and walk back to your office. Another significant issue, which we are really beginning to make some headway on, is that historically telemedicine services were inadequately recognized or reimbursed by insurers. I can say there has been really significant adoption in the past 2 or 3 years for those of you who are on insurance plans. Other issues is that the regulatory environment was really underestimated. If we're talking at the organizational level, maintaining privileges, making sure that liability coverage and an understanding of licensure was well in hand for the practitioners and the clinic. Another issue is if demand for services was not really well vetted, well researched, and that the demand was not really as large or predictable as was expected. And then another issue is if the services themselves lost money because the delivery of care was more expensive or complicated than expected, or if reimbursement or collections were less than expected. So even if you are an individual practitioner, I hope you will think about how this would translate to your office. If you are part of an organization, I think you probably see the relevance of this framework. So in order to take those hurdles into account and maximize success in teletherapy, I'd like you to kind of consider a framework that Dr. Holland and I used in the book that we put together. He was a wonderful collaborator, unfortunately passed away a couple of years ago, but he has a career of experience in technology adoption in organizations. Together we wrote a book that really used a metaphor of the theater. So we'll begin by saying, would you build a building without blueprints and construction plans? Or in our metaphor, would you put on a play without a script, without actors, sets, or contracts in place? And the risk to any telemedicine project is significant unless you really put the steps in play to make sure that your play is ready for prime time. Our next letter for your CE credit is F. This kind of reminds me of Sesame Street, but remember the letter F. So then let's talk a little bit about the metaphor that we used in our book. So an organization or a practice can be thought of as a theater company that strives to give a satisfying performance to an audience of customers. Thinking of theater as a metaphor, each of us get up in the morning and put on our work clothes, i.e. our costumes. We travel to our office, the theater or set. We execute our jobs, i.e. we have a role to play. We provide that role according to our practice's goals and objectives, i.e. that's the script of the play, in order to deliver services to clients. That's our audience. That's our customer. And so adopting teletherapy, I want you to think about the conversion in your office somewhat similar to beginning a small, maybe even a single performer theater company, and the transition is adopting one play to another, that you are going to be changing your office practice in a way that's somewhat similar to putting on a new play. And so adopting teletherapy involves a transition to a new way of operating that includes both new technologies and new systems in your practice. And while you're doing that, you have to simultaneously run your business and change your business, i.e. I don't know of anybody who is converting to 100% teletherapy. There may be a few exceptions, but for most folks, there's a really hybrid of in-person delivery, i.e. running your existing business, adopting teletherapy. That's the process of changing your business. Part of the aspect of changing the play is that you have to start by selecting and communicating a new script. If you're going to change your organization from one way of delivering business to another, you have to start by crafting a new vision of how the organization is going to operate at some time in the future. In other words, I want you to think about what does your practice or organization want to achieve by adopting teletherapy. In that sense, I want you to think about what's your business model. What's your business right now? Where are you trying to have it go? And how do you intend to get it there? So how does the incorporation of teletherapy figure into the business model of your practice? Is it to expand to new geography? I see clients all around the state of Texas. Texas, as you may know, is over 1,000 miles across. So I have been able to see clients across the state. And so without being confined to the, let's say, half-hour travel time in Center City, Houston, I now have a practice that can expand across this region. Another opportunity to think about, is there a specialty service that I offer that I would like to be able to make a statewide or a regional delivery approach as opposed to confined to my office? Do I hope to maintain continuity with existing clients? For some of us, we may be treating adolescents who are going off to college within the state, and teletherapy would be a way that we would provide continuity with clients who are no longer living within that half-hour proximity of my office. Another opportunity is that teletherapy offers an opportunity to de-link your practice from your fixed office location. I've worked with some practitioners who have a vacation home, and they practice 3 days a week, half days from a vacation practice, even if that's out of state. I've known some practitioners who have opened up a home office, and so it begins to separate us from the fixed office that most of us kind of grew up with. The next aspect to think about are the roles of the practitioner in teletherapy. So if you want to change the play, you have to identify and reassign the roles that are called for in the new script. If you want to change the organization or the practice, you have to alter the work processes of the practice so that the work is put in place for this new way of doing business, and that implementation is systematized. And I would really encourage you to really write down your workflow in terms of how you expect your practice to alter. So let's talk about some ways that your workflow may be changed. How are you as a clinician going to deliver your services remotely? Do you have the technology on hand? Are you looking at a laptop computer that is ready to host competent teletherapy? We'll circle back to that in a minute. How are you going to identify, how are you going to ascertain that your client is who your client is and their location is verified? I need to know that when I begin with a client that they are a resident of the state of Texas and that I am delivering services in Texas. That's a licensure requirement of mine. I also want you to think about what are the support systems that are needed on your side of the camera and your client's side of the camera in order to make sure that you can competently deliver teletherapy, and that if you need technical assistance, that's available. How are you going to manage your medical records? If you are a physician, how are you going to manage your labs and prescriptions? For most people, if we're seeing an individual in another location, we can continue to use our existing record system. If we are going to be going from organization to organization, we need to think about, do we have an EHR that will communicate with the EHR on the other side? Am I going to print PDFs and email those over secure email to the client organization that I'm consulting to? How are you going to manage schedules and payments? Are you going to take credit card transactions? Will you allow your clients to see your schedule and book an appointment or use an intermediary service? I'll talk a little bit about some of the either bare bones or full service telemedicine platforms that are available for therapists. Next, let's think about the new technology, which really is kind of the equivalent of the new set for a play. If you want to transition to a new play, you have to select the theater, build the props, and fit your costumes to the actors. If you want to transition a healthcare organization to a new delivery model, old equipment has to be altered, or new equipment bought to enable the practice's new work processes. Another thing to think about, if you're putting on a play, do you have performance rights? In the theater, do you have permission from the author to put on your play? Are the actors in an actors guild? Has the fire marshal approved the theater? Let's make the translation to teletherapy. Do you know the regulatory requirements for delivering services in your state and in your profession? Those vary widely. So we have 50 states, and we have professional organizations that range from psychology to psychiatry to social work, marriage, family therapists, licensed professional counselors. Those regulatory requirements differ by profession and by state. And it's really incumbent on you. My recommendation is to become aware both of your state regulations and your own individual licensure regulations as they relate to the delivery of teletherapy. The American Telemedicine Association and CTEL, which is a law firm that has a great website that summarizes regulatory requirements in telemedicine, is really a good starting place for you. Occasionally, there are still states, Texas is in the process of making changes in requirements for delivery of telemedicine. There's been a long-standing legal dispute, but Texas is in the process of converting from requirement for in-person view of a patient, in-person sessions prior to telemed or medical telemedicine. They do make an exception. There are different standards in Texas for behavioral telemedicine and medical telemedicine. Just an example, get familiar with your own state and your own professional licensure requirements for telemedicine. In general, we can state that the encounter is really right now considered to occur where the patient is located. With the exception of the VA and Indian Health Services, in most cases, the regulatory requirement is that the doctor is licensed where the patient is located. And so that's where my comment about confirming your patient's identity and location is important. I need to know that my patient is a Texas resident and I'm delivering services in Texas. If you're a physician, there are restrictions on prescribing controlled substances that you need to know about. They vary about whether you are prescribing to a hospital or another environment like another physician's office like primary care. In general, controlled substances is not authorized prescribing direct to consumer in their home. I really encourage you to be familiar with that if you are a prescriber, to know about the difference between prescribing a benzodiazepine and an antidepressant, that you really need to know carefully that you are within federal guidelines and state guidelines for prescribing controlled substances. So as I mentioned, you need to know that your client is located in your state or a state that you hold a license in. I encourage you to confirm that provision via Tele is addressed in your professional liability policy. I recommend that you amend your informed consent so that your client acknowledges that you will be delivering services via Tele and that there are any limitations. There are some good models out there for informed consent policy that may be helpful to you. It is important to have, as you begin with a client, to have contact information, which includes address, cell phone number, next of kin, a protocol for what happens if there are technical difficulties, or how you would respond in case of an emergency, and that you've authenticated your client's identity and location. Many times, we are using computers that are perfectly competent for delivering secure video conferencing. So most contemporary computers that have a camera and a fast processor is going to be good, but it is good to know that you're running on a fast contemporary personal computer or laptop. It's also important for you to know how data security and HIPAA compliance is going to be managed. I am very reluctant, although it's widely done. Practitioners may use Skype or FaceTime or other consumer grade. There is a great deal of gray area and controversy in the field. Even if those systems are encrypted, they may not meet standards for HIPAA compliance in terms of business associate agreements. So I really encourage folks to use systems that have a well-vetted HIPAA compliance and data security component, and that you're not using a consumer-grade video conference technology. When you use really what I'd consider a dedicated teletherapy platform, make sure that you have tech support available both to yourself and to your client. It's really vitally important in delivering good care that you know that you can provide competent audio and video, and that someone can debug the system if there's a technical problem, that you know that you have ready access to tech support, and that you understand if there are additional costs that are involved. It's important also to really determine what kind of setting you're going to be delivering services in. If you're going to be delivering services to a clinical setting like a clinic or a hospital, that you will likely have IT on the other side. If you were delivering services to a patient's home like I do, I strongly encourage, as I do, using a system that has embedded tech support and HIPAA compliance. There are a variety of affordable platforms that are available now. I think just like all of us will consider having office rent as a business expense, I would really say that teletherapy merits having a dedicated cost in your system. It can certainly be scaled, meeting your needs. Some of these systems are very low cost with low feature, in other words, have audio and video only, to other platforms that offer much more full back office services, which may include scheduling, billing, and a web presence for your practice. So as you look at available options out there, really look at scaling the technology to the extent of tele-delivery that you expect to incorporate into your practice. Part of that investigation is really looking at the features and price point that fits your practice. Research the available vendors. I have found that vendors are quite willing to get on the phone, to demo their systems, to talk about their price and features, about their tech support, to do some of that background investigation. Similar, you would not rent an office over the phone and start paying your practice rent. You need to go out and vet the system that you choose before you make a decision. We'll be talking more about this, but it's really important to test your system before you go live with a patient. Establish that you have the technical support protocols that are available both for yourself and your client, and that you are really accountable for having a support system both for yourself and your clients to be able to confidently and competently provide teletherapies. So now let's talk about the dress rehearsal. If you're going to change the play, you have to put actors on contract for the new play and rehearse them so they can perform their roles perfectly. As a practitioner, I want to know that I'm competent in delivering my care over a competent technology system before I go live with patient number one. So if you're going to change your organization, the performers have to be under agreement to provide an altered job description, and the goals and the training has to take place that accompanies the technology adoption. So let's think about this as your office now as a set for your one-person play. It's really important for you to know yourself on camera before you go live with a client. One thing that I do, I have several different systems on my computer. They allow me to turn on my system and see myself. I use Photo Booth on my Mac, which shows me in my office what I look like in my office before I go live with a client. Additionally, I strongly recommend, once you've adopted a system, that you go live with a trial session with someone who is perhaps a tech support from your vendor, an assistant or a colleague who will tell you, frankly, how you look on camera and make adjustments to your audio or video so that you know you are delivering yourself in a way that you can stand behind. Don't expect that your clients will tell you if your presentation on camera is a problem. They may be consciously or unconsciously reluctant to tell you that you are not coming across well. We're going to go into that further in a few minutes. But your office, your presence on camera is the set for the play. And your visual appearance and your audio sets the tone for your client working with you. It's really important that you test your lighting before you go live. Adjust your lighting so that both sides of your face are equally and warmly lit. Make your background professional, not too busy. Things like bookcases, diplomas are okay. Watch out for glare that can be very distracting. When the camera is looking into a glare, it presents a visual problem that's quite distracting for clients. Avoid clothing even that have very complicated designs. You don't want that busy checkered sport coat with the bright colors. Bright colors and complicated patterns tend to be what I call buzzy on camera. Your wallpaper or your art behind you may either be soothing or distracting. Again, that's why I want you to look at yourself before you go live. In terms of audio, echo and delay are the most common problems. That needs to get sorted out before you go live with clients. That's where I think having tech support is vitally important. I consider audio breakup more serious than video breakup. Clients are able to take a little bit of freeze in the picture and really stay with the session much more readily than they are hearing a breakup in the audio. That's where we have that opportunity to misunderstand our clients. Another critical thing, it's good practice in person as well. Wait for your client to speak before replying. Video conference audio, sometimes competing audio channels will create some distortion if you try to speak at the same time. So good practice to make sure your client has paused before you reply. As you can see, I'm wearing earbuds. Earbuds or a good USB headset will eliminate many of the problems that may occur with echo. Microphones are very sensitive. They pick up extraneous sounds. I have worked with some practitioners who used a desktop microphone, found that they had a habit of tapping a pencil on the desk. These things come across loud and distracting to the client, even though the practitioner may not be sensitive to it. If the audio is distorted and your client's verbalization is unclear, please ask them to repeat. Don't try to think you understand verbalization that was distorted. Otherwise, you may miss something important. I repeat my client's statement in order to confirm that I've understood them if there's any chance that there was audio distortion in the play. Fascinating study that was done about tuning the video conference environment. Eye contact is really critical for good engagement with your client, and minor variations can have really significant effect on client perception. There was a wonderful study that was done about 10 years ago that used a video conference system, and all they did was they varied the camera angle a little bit. They used one set that really involved a good direct gaze, the doctor making good eye contact with the camera so that the client saw the doctor making eye contact. When they did consumer ratings of the doctor was rated as interested, competent, and attentive. The next condition, they changed the camera angle so the doctor appeared to be looking downwards while they were interacting with the client. The patient satisfaction said that the doctor appeared to be disinterested, sad, or even if you said, "Is my doctor on drugs?" We don't want that. I took some screenshots of myself. You tell me what client view is best. This is me in my office. with the blinds open and the curtains drawn. You can see the glare. This is me with the drapes down, the blinds open, but with my dry arrangement behind me. I had a client tell me, Dr. Kyler, what is it that's growing out of your head? So I learned to move that dry arrangement. This is me looking downwards. This is me making eye contact. I think it's pretty evident, I think, for all of us, what would you as a client want to see of your doctor? We want eye contact. We want a non-distracting background. We don't want glare. So that's just a really simple example of how I can vet how I look on camera. Next, let's talk about job roles. If you were in an office or clinic, how is the practice of teletherapy going to change the workflow of your office, both yourself and your staff? What kind of extra steps may be necessary? One of those that I really do focus on is how important it is to have the practitioner training. I've worked with a number of systems where I've put together competency testing so that practitioners really know about the evidence base, they know about technology and how to test their technology. If your staff is going to be involved, make sure that they are competent on the technology system, if they will be setting up the camera before you go on camera. In other words, how are the participants in your practice or your clinic are going to change the workflow to incorporate teletherapy into your delivery of care? Then when we talk about moving the transition, managing change, transitioning from an old way of business to a new way of doing business, how are you going to transition so that the moving parts are treated as a project, you follow a schedule for vetting your technology, altering your work processes, understanding your technology, making sure that you're competent on camera, that you know how to use the equipment, your office staff is on board. Those are all the steps whether you're a single practitioner or a large organization. And any change process benefits from having a project plan. Imagine a director who's communicating a new play to a theater company and said, we don't need to read that long script. I've prepared a couple of PowerPoint slides that will explain the play in a couple of minutes. Well, that's not enough. Here's an example of a script that I've put together that really has to do with how the practitioner articulates some of the fundamentals in the first session to a client. Have you ever talked to a doctor on camera before? We're going to be talking today just like we're in the same office together. Please let me know if you have any problems seeing or hearing me. If you have any trouble hearing or understanding me, please let me know, and I'll be happy to repeat myself. I'll ask you to repeat yourself if I have any trouble understanding you. I've taken steps to make sure that our visit is private and confidential. Our visit isn't going to be recorded. Please make sure as we continue that you're in a place where you can expect privacy and be free of interruptions or distractions. That is essentially one of the first interactions that I have with a client to get them on board with this new script. So what are the expectations of your client, of the audience? That one, we expect them to be in a quiet, private location. I cringed a couple of years ago when I read a story, I think it was in the New York Times, about just how cool teletherapy was. And they quoted a client, a woman who said, God, isn't this great? I sit with my iPad on my lap on a floaty in the pool drinking a mojito while I'm talking to my therapist. How many of us would be comfortable with our patient drinking alcohol in session while in a bathing suit? I think we want to communicate setting to our client as well about what's appropriate and what's not. That we agree on both sides that we're not going to be observed by others unless both sides would agree. I've been in settings where I've introduced a new practitioner by shadowing another, but we introduce that person on camera. We get permission from the client to know that there is essentially a trainee who is shadowing the therapist. Make sure you use a device with adequate screen size. We can do a lot of things on phone before. I don't think teletherapy yet is something that I want to do on my iPhone 6. I want to have a laptop-sized screen to really make sure that I see my client in sufficient detail, and that they are also seeing me in sufficient detail. I also want to clarify with them to what extent I would communicate with them via text or email. I use a private secure portal for email to interchange with clients over my telemed platform. I encourage you to do the same. If clients choose to text, I also make sure that I address expectations for privacy. I tell my clients, if you were going to text me, it would be for purposes of changing appointment times or basic communication like that. I will not communicate any essentially personal information via unsecured text or email outside of a secure portal. Well, what happens when the audience is a home viewer? I see clients in teletherapy who are at home. Well, one interesting thing is I can learn things from observing my client in a home setting. I have a client who's profoundly depressed for a period of time, and as I booted on the camera, at 1 o'clock in the afternoon, she was still in bed in PJs with a blanket up to her neck. That would not happen in the office. It tells me something about this client's current functioning in a home setting in which she has not gotten up, gotten dressed, and gotten mobilized. I can guarantee when she's come into the office, she's been dressed as expected, but I found that I learned some things by seeing my clients in their home environment. Is the home that we see organized or chaotic? Is it dark or well lit? Those are some things. We know we give up a lot of things by not being in person with our client, but I have to tell you there are some things that we learn by seeing our client in their own home environment. In terms of the therapeutic connection and the technical connection, I want to pass along some thoughts. One is that there's increasing evidence that many, if not most clients, can be as comfortable or even more comfortable disclosing themselves via tele as they are in the office. That, I think, particularly with younger folks who are conducting so much business over devices, that is certainly the case. I think there are also people who are more willing to self-disclose when there is a little bit of a distance, and that technology provides a distance that really can sometimes facilitate self-disclosure. It's really important to solve technical problems actively and promptly so that your therapeutic alliance is not damaged by technical problems. In my own experience, clients who have a good therapeutic connection with me most typically will take technical blips in stride. There have been rare occasions where I've had to convert to finishing a session via cell phone because we've had audio breakup. Most clients take that in stride without a problem. Clients who are early on in treatment, in distress, or who have a shaky therapeutic connection may also be very reactive to these technical blips, which is why I'm a big fan of having strong technical support. What we don't want are our technical problems to get in the way of having a strong therapeutic connection to our client. There is a possibility also that a reactivity to technical blips may be a surrogate for concern about other aspects of the therapeutic connection. So I want you to think broadly about the connection with the client, and that it's both our human interchange and our technical interchange that have to be in good working order to do good therapy. So what are some of the limitations? Well, we don't have access to handshake, to smell, full view of body language. There's a learning curve for the clinician to get comfortable, and there's a learning curve for each new client to be comfortable with using technology as a way of connecting with you. It's important also that we have early identification of a high-risk client so that if there is someone who is really not suitable for tele, maybe in significant acute distress, suicidal or homicidal ideation or plan, domestic violence, that tele may not be the right venue for this client. If there is a client that does have some degree of risk, that you've developed and worked out an emergency plan if risk is identified. As I mentioned before, for physicians, there are limitations on controlled medication prescribing. It's really important for you to be aware of that. So I think we can safely say that tele really provides great opportunities. I think for all of us, if there were an option for the client to come into the office obviously we would go with that. I like to think about Tele as compared to what? If Tele is an opportunity to match a client to a qualified therapist who would not otherwise have access to care or have access to specialized care, I can strongly say that Tele is the preferred mode of delivery because I'm confident both of my own use of the device and experience in conducting care, and that there's an empirical base that gives me confidence that I can deliver competent, effective care as readily over Tele as I can with a client in the office. In conclusion, technological delivery of healthcare is here and it's growing exponentially. In so many ways, behavioral health, because our technology needs are simple, we are ideally suited for the technology delivery of care. Consumer demand is very, very strong. I can say also that traditional models of care are under pressure. I think we're all probably aware of the pressure that managed care placed on our professions. Technology is bringing in a whole new kind of pressure. When you think of what happened in the transition of movies, the transition from movie theaters to blockbuster video to streaming video, that may be an extreme example, but be aware that the transition in healthcare is following somewhat of the same model, in that what used to be a big box delivery and then a slightly different big box is now moving to personal delivery over technology. Those same trends are happening very strongly in healthcare and in behavioral care in particular. So I think we can say we are in the midst of a paradigm shift to some extent. There's an intense growth of computerized CBT models. There's reasonably good evidence base that computerized CBT can be effective. There's still a lot to be determined in terms of which clients are really best suited, what degree of actual live clinician involvement is optimal, is adoption, is high adherence and compliance with computerized delivery of care adequate for delivering services. There's an explosive and I would say very controversial growth in text therapy. As you're probably aware, there are a number of platforms out there that engage clients at a distance, that offer a fixed fee per month interchange of text visits back and forth between client and clinician. I won't go into it. This is a very fast-growing and quite controversial style of care delivery. The other thing that we can say is that our regulatory environment is probably 10 years behind technological development. It is really important to understand the regulatory environment, but know that technology is way out ahead of us. Many of us were really not trained with technology as part of our delivery platform. How are we going to adapt? And as we adapt to these new delivery models, how do we maintain our integrity, our boundaries, and regulatory compliance in using technology to deliver effective and competent care to our clients? Questions? Mary, I think, is going to field questions from the field, and I'll be happy to answer those. Mary, if you will maybe identify the questioner and let us know what the questions are.
Absolutely. We do have a few questions that have come in already, and I just want to remind everyone that you can still submit questions through the chat pane in your attendee control panel. Okay, our first one is from Lisa Dominguez. She asks, what are the issues to consider if you are licensed in one state but are providing teletherapy in another state?
I think the issue to consider is that you are at risk. And I think as a practitioner, you need to be aware of any potential risks that you are taking. For most practices outside of the VA or the Indian Health Service, in our country right now, the regulatory environment considers the site of care to be where the patient is. The risk would be if there were a complaint about you and your service. Let's say Bob is delivering services from Texas to Colorado, and my client in Colorado makes a complaint to the Colorado Psychology Board, and they're going to say, who is Dr. Kyler? He doesn't carry a license in Colorado, and what the heck is he doing delivering services out of state? That may come to the Texas board. And so there are risks that you should really be aware of. I certainly do know that there are many practices and practitioners who have made their own internal risk adjustment, that they have seen a client for a period of time, they have a good therapeutic connection, and they are comfortable in taking the risk, for example, in saying, my client who is now going off to college in another state, I will continue, and the continuity of care is for the client's benefit, and I will make a risk calculation that nothing will go wrong and that my client will be safe and they will not complain to me about the board where they are and not where my license is. So I want you to be aware. It's very commonly done. If you're going to do it, learn about your own licensure standards within your state and profession. Be aware of those risks if you choose to take them.
Thank you. And then a few folks participating asked you to please give examples of HIPAA-compliant teleplatforms.
Sure. Breakthrough Behavioral, which is part of MD Live. Disclaimer, I've been a consultant for them for a long time. Insight Telepsychiatry, Innovatel. Mary, you know, maybe the thing to do, rather than going off the top of my head, I will be happy to have emails from folks, or maybe what I can do is to send a list to you offline that you could then send out. So I want to make sure that I'm not leaving out some of the ones that I'm, you know, that are really well-vetted platforms. So if you're agreeable to that, I will send that out, and then you can make those available to participants.
Absolutely. Natalia is asking, do you also have any recommendations regarding a fax application, sending a fax from a computer?
No. The platform that I use has an email and messaging, and so it allows me to send a PDF back and forth. And so as you know, what I'll do is when I send out the list of telehealth providers, I'd encourage you to go on their websites and look at the features that they deliver. Some of them do really have secure delivery that is available within their platform. And so that's the way that I would say important for you to vet whether you want a bare bones video only or whether you want more back office or messaging function available to you.
Great, thank you. Debbie is asking, can you please address the insurance billing codes that you would use when billing for the clinical work?
Sure. There is a GT modifier that was developed by Medicare. It's also worthwhile looking. Medicare kind of set the precedent, and so that GT modifier attached to a psychotherapy code or an E&M code is really considered the billing parameter that designates that a service has been delivered by Tele. And most insurance companies that are now covering, if you were on their platform, I would encourage you to go to an advisor within that managed care company to make sure that your services are covered. And if they use any coding differently, but essentially the industry standard is your therapy code with a GT modifier attached to it.
Sorry, I was muted. It looks like that was our final question. Do you have any closing comments, Dr. Kyler?
Yeah. In my own experience, I have really found adopting telehealth to be exciting and invigorating. I encourage you, if you are going to take it on, to do some homework. If you're an individual practitioner, it doesn't take a huge amount of homework to get yourself ready. But I think it's really, you know, my own comfort level. Before I do something live with a client, I want to be comfortable and confident to know that I'm coming across in a professional way, a way that I understand how I'm engaging and communicating with my client. I want to make sure that I'm having that I have a sound technical platform, the same way that we put thought into where our office is and how we furnish it. We are really presenting ourselves to our clients in a certain way. We communicate something about ourselves by the setting that we practice in, and I want you to think about yourself in that same way, that you have a virtual office, that you don't go to a Starbucks probably and sit at their chair and interface with your clients. You have a professional office and you are in control of that setting. And I want you to think about Tele as a way that you can create a virtual office. It's not very complex to do. As I mentioned as I began, it is so simple and so cheap to do it now that I encourage you to put the homework in to make sure that you are delivering care in a way that you are comfortable with. I have found that clients readily adopt seeing me over Tele. We have what they call kind of the 15-second rule. I was the interim CEO of a company that provided 100% telepsychiatry services to emergency rooms, crisis intervention settings. Clients got it almost immediately, and the vast majority of them were comfortable. And actually, in my experience, I can probably count on both hands the number of clients that ended up not being comfortable with a Tele and needed a face-to-face. It is a hurdle, I think, that is more present many times with practitioners than it is with consumers. If you do your homework, I think you're going to find that it's invigorating, that it will allow you to spread your expertise, to expand your practice, do it in a way that you feel comfortable with. I really want to thank you for participating today. I'm certainly happy to take any questions via email. My email address is on the screen, or you can route through Mary. I will put together kind of my go-to list of the vendors that I think you ought to look into. And with that, Mary, thank you so much for the opportunity.
Oh, thank you so much, Dr. Kyler, and thank you again to our participants for attending today's webinar. Once you leave the webinar, you will receive an evaluation of today's presentation, and we would appreciate if you would complete that and provide your feedback. You will also receive a follow-up email within an hour with a link to view a recording of this presentation. And we, of course, hope that you'll join us at the Anxiety and Depression Conference April 6th through 9th in San Francisco. And on behalf of ADAA and our presenter, thank you for joining us today, and have a great rest of your day. Thank you.
Thank you.